us how to do good quality radiotherapy.
Thank you very much. Can you see my slides?
We can, thanks.
Yeah, wonderful. No, thank you. And thank you very much for giving us the opportunity to kind of go through a few pointers that we kind of think about when we're planning patients for prostate radiotherapy. And let me just forward, sorry. So I kind of gave the title of Precision Art for Prostate Radiotherapy. And, you know, I very much, when I discuss with patients describing the process, I do sometimes talk about how we're going to draw around the prostate and draw around the structures of interest. And I quite like this illustration here, is that, you know, kind of there was a class of artists who kind of were asked to draw the Van Gogh sunflowers, and this was kind of their kind of result. And, you know, kind of it's a bit more attractive and colourful than on my prostate contours, so hence using. But let's kind of go through a few factors that we think about when we are outlining. As Alice mentioned, you know, kind of the outlining process is a really essential part of the patient pathway for prostate radiotherapy. So some factors that I consider when we're thinking and sitting down with the patient, and also when we're planning. So first of all, thinking about patient history. You know, from the data we know that patients who have symptoms affecting their bowel or urinary function tend to do worse after radiotherapy. So very much trying to make sure that we can optimize those before we start prostate radiotherapy. Also about whether they've had previous radiotherapy, that's also very important to take into consideration. And then also, I think, patient expectations from the treatment. You know, sometimes when we discuss about side effects after they've had treatment, you know, their disappointment that their urinary symptoms haven't got better is something that we kind of need to make sure that when we're discussing with them about prostate radiotherapy, the aims and expectations. The other thing, obviously, is then clinical parameters. So making sure we've got all the information in front of us. So using the MRI, using our biopsy and PSA, really to help to decide kind of what our target volume will be. And then using the anatomy. So I find it quite useful looking at the diagnostic imaging, both also for looking about bowel distribution. So whether that is potentially going to be something that we need to be aware of when we think about planning the radiotherapy, but also the rectum size. So, you know, I'm sure there'll be a lot more discussion about that for patient preparation, but sometimes it's very useful to look about what the rectum size was on the diagnostic imaging. Then when you come to look at planning, then it kind of makes you know whether that's an outlier for the patient or whether that's typical of what you're seeing. And then the other aspect is how are you going to deliver the treatment? What image guidance mechanisms are you using? And you know, kind of margins and those type of things. So those are some of the factors, you know, to consider for radiotherapy. Then looking about what we know for contouring. So we know that MRI compared with CT is superior in terms of contrast resolution, and allows us to have better visualization of the prostate and the periprostatic structures with that. But currently, at the moment, I think the majority of us are using CT with the aid of MRI to help us in prostate gland delineation. I know my colleague, Dr. Tree, is very keen for us in the future to be able to plan on MRI, and that is something definitely, hopefully in the future, we'll be able to do. The other thing is that we know that by using both CT and MRI, that does reduce the inter-observer delineation variability by up to 3.5 times compared with just using CT. So I think when we're planning patients, we definitely need to be using CT and MRI, but just be aware of the fusion. So if you are fusing the CT and the MRI, that this can cause some kind of uncertainty in kind of your outlining. So just to be aware of that when you're contouring. I think this is a really good consensus guideline. So it's being produced a few years ago now, but by quite a few colleagues that I'm sure we all know and are familiar, you know, kind of to have heard speak and or been taught by. And it's kind of a really good, it's got some illustrations in there. So I do recommend, and I've taken some of the figures really to discuss today. So as we've kind of been discussing about toxicity, GI toxicity, you know, what we know is that actually we're getting better at finding the optimal dose constraints, so how much dose the rectum should receive. But what needs to be done is the rectum needs to be accurately delineated. And also the fact is the rectum does then influence our contouring of the prostate. So within this, we need to kind of be, when we decide about dose constraints, we think about the volume of the rectum. And so therefore, we have to be quite accurate where we're starting from and where the bottom and the top of the rectal contour is. So if you can look on the kind of panel A, this is kind of just showing where the rectum kind of turns into the sigmoid. So it's kind of where the rectum turns horizontally, so goes forward anteriorly. That's where that transition point is, where you then kind of start contouring the bowels of the sigmoid colon. What they recommend in the guidelines is that in the axial plane, kind of outline the rectum on all the slices where you can see quite easily the difference between where the rectum is and the prostate, because there are some slices where it's very blurred, and then there's other slices where you're like, brilliant, I can see this. And so on those slices, to outline where you can see it, and then use the interpolation tool. It's brilliant now that I think all planning systems have this. And always go back to the sagittal plane. I think it's really helpful to be able to see with something protruding out, doesn't quite look right, is this a typical shape? And so those are kind of some rough guidelines with regards to contouring the rectum. The other structure, which kind of also I think is quite an important structure for contouring, we have got some dose constraints for this, is the penile bulb. So at the top you can see some slices, and on the bottom, unfortunately, it's not come out very clearly, but these are some contours of the penile bulb. And so this is the area kind of just immediately below the GU diaphragm. And the way that it recommends that you should be contouring is that it should be kind of, the penile bulb should be posterior to the urethra and has a round shape. And that the reason why it's important to kind of identify where the penile bulb is, that sometimes, if you're struggling to see where the apex is, that you can use that as a rough guide as to where the apex should start. So roughly, from studies that have been done, the apex, the prostatic apex, which is probably the most challenging bit of the prostate for contouring, is roughly around 1 centimetre above the upper border of the penile bulb. However, the way that I think is useful to do is, if you've got an MRI at the time of planning, then definitely please use that to identify the apex, because from studies that have been done, you can see that there's the variation of where on MRI versus CT. Sometimes if I haven't got an MRI at the time of the planning scan, I then sometimes actually start in the middle of the prostate, because I think sometimes it's quite nice to get your eye in where the prostate contour looks, and then contour inferiorly down and check. And then also do have a look at the diagnostic MRI to see roughly where that apex was. Obviously, patients may have had started hormone therapy, which does slightly affect the shape and size of the prostate gland. Then in terms of when you are in the mid prostate, so the lateral border of the prostate is the levator ani, and you can see it probably quite nicely better defined around the rectum. And so the thickness, even though it does vary, they recommend that you just assume that the thickness around the rectum is similar to what it is around the prostate, just for kind of defining where your lateral borders are. Obviously, if you've got extension into the levator ani, then you need to encompass that. And then in terms of the anterior border, so as you can see here on this slide on the right, it kind of has got the red circle. So this is kind of the retropubic space, and within this it's got fatty tissue, and it's also got the Santorini's venous plexus, and anteriorly you're covered by the prostatic fascia. Now that's a very similar density on CT to the venous plexus, and so sometimes that can cause a bit of uncertainty. But I think kind of if you're not using an MRI, then actually just kind of do make sure that you encompass the fascia, and sometimes you will end up including the venous plexus within that contour. And as they mentioned, 25% of prostate cancer include the transition zone and can sometimes breach that anterior fascia. And then, as we know, the posterior border is very much the anterior border of the rectum. And so once again, that's really why it's very important that we have good contouring of the rectum. And then another tricky place, which I do think, is that the base. I think kind of defining what is kind of where the prostate finishes, and then when you kind of have kind of the bladder wall and that impact. But I think kind of just looking on the sagittal, I think, is always very helpful to have a look to see about how far you extend for the base. Then the other bit that I think kind of when we're viewing contours and does have quite a lot of variability is about seminal vesal contouring. And I really like these kind of ways now of thinking about how much seminal vesicle to include, and I've kind of taken this from the PACE protocol, which Dr. Tree kind of developed in terms of how to guide us really to how much to include of the seminal vesicles. And so the way to do this is to contour the prostate first, and then you can do kind of an isotropic expansion of 1 centimetre or 2 centimetres, and I'll kind of show you kind of different risk groups as to which kind of the inclusion of seminal vesicles and the dose for that, as a guide really to say how much of the seminal vesicles you should actually include within your different CTV volumes. And then with patients who have got disease at the base, to kind of include the base of the seminal vesicles for those patients, and then obviously for those who've got a seminal vesicle involvement. So this I've kind of just extrapolated from the PACE protocol in terms of how much of the seminal vesicles to involve, and once again using this isotropic margin, and the way of doing it is contouring the seminal vesicles using your kind of isotropic margin and then editing where that 1 centimetre or 2 centimetre ring has kind of cut off where you should be treating. So for low risk patients, I think all of us would agree that actually we shouldn't be treating these patients with radiotherapy. They should be on active surveillance. Patients with intermediate risk factors, we recommend kind of prostate plus proximal 1 centimetre of the seminal vesicles. For those with high risk factors, the high dose to receive would be prostate plus proximal 1 centimetre seminal vesicle, and then for the seminal vesicle for the extra proximal 1 centimetre to receive the lower dose. And then for patients with high risk, say for T3B disease, to put in the high dose area the prostate and the involved seminal vesicle length. And if that involved length is less than 1 centimetre, we'll then definitely include 1 centimetre at the minimum, and then for the full length of the seminal vesicles to be included. It would take the whole session over if I then try to start talking about pelvic lymph node contouring. But I think with prostate radiotherapy, we've got some great radiotherapy trials within the UK, and actually looking at the radiotherapy planning guidelines. So we've got a number of trials which are looking at that, including Pivotal Boost, PEARLS and PACE nodes. And also we've got the NRG Oncology Consensus Atlas, which is also very helpful in guidance on this. Just kind of in summary with regards to our inter-observer variability, I think the thing is to know that this is found in all treatment sites. It's not just, kind of specific for prostate. When looking at studies, there's very much there is reasonable agreement for prostate contouring, and the most variation tends to be within the apex of the prostate and within the rectal contours. So those are the things that we can all kind of focus on a little more. And then I think it's really good that we've got more imaging tools, and we should really make sure that we use everything that we can to aid in our contouring. And the same really with patient preparation. So in terms of bowel preparation and bladder preparation, I think ensuring that those are as similar as they can be for when the patient comes for their planning as well as their treatment. And then the other bit really is about peer review, which is really an essential part, and that can be something that can be discussed in the panel. And also now more centres are getting involved with automated contouring. I think, as we know, and Isabel will kind of now lead on, is that we know that these variations in contouring can cause an impact on dosimetric parameters, and we know that that does have an influence on toxicity. So it's really important that we try and optimise this as much as we can for our patients and for potential consequences from this. So I'm now going to hand over to Isabel, who's going to discuss about